it's on the list. I mean, forward to your, yeah,
No.
sure, yeah.
¿Se está viendo? Listo.
Okay. Tired. Espera, things that like my much less.
La hora
Very
que-
good. Your photo. Okay.
¿Empezamos? ¿Qué?
Segundo.
Oh my God.
Yes.
¿Estamos al aire?
Ya.
Buenos días. Buenos días. Vamos a dar inicio a nuestra sesión académica de hoy del Departamento de Salud Mental de la Fundación Santa Fe y de la Universidad de los Andes. En nombre de nuestro director, el doctor Juan Carlos Molano, quiero dar la bienvenida a este importante evento que vamos a tener hoy. Muy contento de que tengamos acá estudiantes, residentes, nuestros colegas de la Fundación, investigadores, bienvenidos, bienvenidas todos. También las personas que se están conectando a través de nuestro canal de YouTube de la Facultad de Medicina también son muy bienvenidos y bienvenidas. Y si tienen alguna inquietud pueden hacerlo sobre el chat. Aquí tenemos la posibilidad de compartir. Lamentablemente no tenemos traducción. Las conferencias van a ser en inglés, no tenemos traducción. Le pido disculpas a las personas que se han conectado esperando que tuviéramos, no pudimos tener la traducción. Van a ser conferencias en inglés. Como acostumbramos en algunas de nuestras sesiones académicas, las hacemos en inglés y si alguien quiere hacer una pregunta en español, la puede hacer y alguno de nuestros colegas versados en inglés la podrá traducir. Tengo el honor de presentar dos profesores invitados que nos honran con su presencia, con los cuales estamos trabajando un proyecto hace ya algunos años, el proyecto del cual ustedes me han oído hablar, el proyecto del mapeo de estrategias de salud mental en jóvenes víctimas de conflicto, que estamos trabajando con la Universidad de Birmingham en el Pacífico colombiano. Hemos aprendido muchísimo de ellos. Yo he compartido con ustedes algunas de esas experiencias. Este proyecto es un proyecto financiado por el Fondo de Investigaciones del Reino Unido y por el Ministerio de Ciencia y Tecnología colombiano. Ya llevamos 3 años largos en este proyecto. Estamos entrando en la parte de conclusiones. En este proyecto hemos trabajado del Departamento de Psiquiatría, Carlos Ignacio Orjuela como residente y yo como investigador. Los investigadores principales por parte de la universidad son el doctor Juan Pablo Aranguren, la doctora Mónica Pinilla aquí presentes. Paul Jackson, politólogo, experto en conflictos, ha trabajado en muchísimas partes del mundo investigando las consecuencias en conflictos armados, la resolución de conflictos. Tiene varias publicaciones y pues con él hemos compartido muchísimo de su experiencia. Muchas gracias. Thank you so much for being with us. Y Sarah Jane Fenton es profesora también de la Universidad de Birmingham. Es una persona experta en sistemas de salud mental, ha trabajado en reformas de salud mental en sistemas, por ejemplo, en Australia. Tiene varias publicaciones y también ha tenido una gran experiencia y nos comparte su experiencia de sus investigaciones y de los trabajos que ha hecho en otras partes del mundo, ahora acá en Colombia. Welcome to School of Medicine of Los Andes University. Welcome to Mental Health Department of Fundación Santa Fe University Hospital. Thank you so much for being with us, and the floor is yours. Thank you so much.
Thanks, you won't hear me if I have my mask on. Sorry. Hello, everybody. I should say that not that I think your English is bad, but my English is terrible at times. I'm from the far north of England, so I tend to speak a little bit quickly. So if I speak too fast, just stick your hands up and shout at me, and that'll be absolutely fine. I'm what's known as people from my part of the country are called Geordies. So Newcastle United, if any of you are into football, and we're famous for it, football and speaking too fast. Nice to meet you all. Like Hanan says, I'm a professor of African politics at the University of Birmingham. I guess I should start with the confession that I'm not a medic. And I became interested in mental health through my work over 25 years in war zones, essentially, and in peace building. So I've done a lot of work with, I suppose, designing and working inside peace agreements. So although I'm a professor of African politics, I don't allow that to confine me to Africa. So I've worked a lot right across the African continent. So I'm probably best known for my work in Sierra Leone immediately after the war, where some of you may know there was a really brutal war with lots of bits of limbs being chopped off and all sorts of things. It was a really pretty horrific war. And I worked a lot with former child soldiers, demobilizing them, both in Sierra Leone and then in northern Uganda, and also a little bit with traumatized populations in Rwanda, Kenya, Mozambique, Zimbabwe, all over. And then I worked alongside a lot of former combatants who were then brought back into work with people who'd gone through that experience. And in the end, I worked with former combatants on both sides. So both former insurgents and also former people who'd worked in the security services who were suffered as maybe slightly different forms of traumas. And I then went on and I worked as part of I was a peace negotiator in Nepal, and I worked quite extensively with the Maoists up in the Himalayas. Without telling my university insurance officer that I was going in jeeps up into the Himalayas to do research with bunches of Maoists. I did that for quite a long period of time. And actually, that is what brought me to Colombia for the very first time. So this is my third visit to Colombia. I've had the first visit I worked a little bit with former FARC rebels, and I brought a couple of Nepali Maoists over with me to speak to a couple of FARC people about what it was like as a politicized movement to go through that transition into a political party. And the Maoists in Nepal, there's no reason why you should know this, but they became a very successful political party. And they were formally elected in an open electoral process twice in a row. So the leader of the Maoist insurgent movement became the president of Nepal a couple of times. So they became a really good and efficient political party, although gradually it being left-wing politics, everybody fragmented and started falling out with each other rather than with anybody else. And then the second time I came across, and I had the great joy to talk to several members of your security services about human rights, which was a really interesting experience. So this is my third visit to Colombia, and I was supposed to come much earlier, but the pandemic rather put a stop to that, unfortunately. And this is something that I've become very passionate about, even though I'm not a medic, because of my 20-odd years of experience of working alongside child soldiers in particular, but combatants and also civilian populations. So I work not just with combatants, but I also work with populations that are receiving former combatants. So people who are living in the villages that actually receive combatants, who are being relocated into those villages. And if you know anything about conflict, you'll realize that that is one of the big bones of contention that people have. Why should we put up with these combatants who then get paid a bit of money? We didn't pick up a weapon or kill anyone. They've been compensated for that, and then they get relocated. Why should we have to put up with that? That is a really common argument internationally. And it affects a lot of people's mental health, both in terms of very specific pathologies of mental health, but also in terms of overall stresses on society and overall stresses on groups of people. And that's the part that I became quite interested in, because I worked on a lot of demobilization programs, particularly in Africa, where you would go to a camp of former combatants and they would be trained as carpenters or iron workers or something like that. And then at the end of their demobilization period, they were given a sum of money, and they were just said, oh, there you are, you're a civilian. And there was no thought to what the process was like of being an insurgent for a number of years, and then actually what it meant then to become a civilian. On top of that, as an economist, you began to realize it was silly training 3,000 carpenters because you've just destroyed the market in carpentry. So you sent them out to compete against each other. So in Sierra Leone, that happened in Sierra Leone. And what happened with that was they all settled in the same area. So you ended up with whole streets of carpenters all competing against each other. And they were all former combatants because they'd all been trained in the same way. So it was completely hopeless. And there was no support. There was no ongoing support. There were very few support mechanisms other than those supplied by the former combatants themselves. And that's kind of where we ended up with this. And I teamed up with various people here. I began to think, or we began to think that there was a gap between medical approaches to mental health issues among some of those former combatants in large parts of the world, and more social approaches, because clearly there were mental health issues, but also clearly not all of those people had access to very formal mental health services and support services in particular. So there was a gap in understanding about, well, what does that actually look like? How do people and communities deal with people who have sometimes quite traumatized histories? They may have been wounded, they may have had, probably usually do have, family members who've been seriously affected by conflict. I mean, Rwanda was probably the most difficult one because if you know anything about Rwanda, you know that they killed an awful lot of people in Rwanda. And one of the things I find most shocking, even though, you know, as I said, I spent 25 years going in and out of war zones, in Rwanda, they still haven't identified a significant proportion of the people who died because they didn't just kill those people, they killed everybody who knew those people. They killed all of their families, they killed all their friends, they killed all the people who could identify them. So they were so thorough that they just wiped these people off the face of the earth. And if you live in a community like that, and you live in a community where you can easily identify people who were involved as perpetrators, then that creates a certain form of societal stress that may result in some sort of medical complaint, but it would certainly result in a more generalized mental health stress on society and you as an individual in how you relate to that society. So that's just a very short introduction of why I'm standing here rather than a psychiatrist or a psychologist. I should say that the Institute of Mental Health, which is the part that I'm part of within the University of Birmingham, is a cross-disciplinary group. So this has been created, it's been running for some years now, and it's a group of people that range. We have a very large medical school, as you do here. So there are lots of medics, lots of psychiatrists, for example, but also other people who specialize in health systems. We have basically health services management center and lots of other areas like social, we would call it social policy when we look at broad systems that support people with very broad mental health issues in the community. Sarah Jane is an example of that. So Sarah Jane is not a medic, but basically Sarah Jane is a specialist in mental health systems specifically and has worked in the UK system. So if you have any questions about the intricacies of the UK system and how it copes, in particular with youth, which is a big issue at the minute in the UK, then Sarah Jane is the person to ask because she not only studies it, but trains a lot of people and has worked inside it as well. So between us, we have a lot of interesting people. So as a group, as a research group, we are deliberately interdisciplinary. I would say militantly interdisciplinary. So we all kind of sort of throw away our kind of our individual disciplines, academic disciplines, in order to work together because we are very focused on problems rather than our own particular disciplines. Anyway, I better get on with it, sorry. My students always tell me off for, my favorite piece of student feedback is always that Paul doesn't really give lectures, he just wanders around talking. And the hardest part is standing still for me because I'm normally just wandering around and I usually completely ignore any PowerPoint slides that I have. So they all think it's great that I do this. So we just want to talk to you about a couple of things. We only have about 5 slides anyway, so it's not a very long presentation. And then we thought we'd give you as much opportunity as possible to ask any questions you might have of us, either about the UK or about the project or about broader experience. So we're just going to show you a little bit. We're part way through the project, so there's not much in terms of results that we can tell you, but we can tell you what we're looking at. And it certainly sounds like it fits in with other projects that are being discussed at the minute, which is really great. And we thought we'd talk a little bit about workforce development and some of the other systems that exist in other parts of the world to deal with this. in particular, but not only with Africa. Some of the mixed systems that you might get to deal with the fact that formal medical services quite often don't reach people that really need a lot of this because they may live in remote areas, for example, or hard to access areas, I suppose. And then we'll talk a little bit about practice policy implications, and as I say, give you time for questions. So we have an interdisciplinary team that you'll see there. You'll see Herman there, looking very cool, as always. We are very deliberately a kind of we essentially are one team, but we have co-PIs. So Juan Pablo, who's in the psychology department here at the University of the Andes, and myself, and we're co-PIs, and it's co-funded by the British and the Colombian governments. And the whole idea of it is that we work very much as a mixed disciplinary team, but everything we do is co-produced and acknowledged for the whole team. And we're very inclusive, and we work a lot with amongst ourselves, but also you can see that we also have quite a lot of links into NGOs and community organizations at the local level. We work primarily in the Pacific region, and the idea of this study is that really we go for depth rather than breadth. So instead of doing a massive survey of everybody in Colombia, we're looking very specifically and drilling down into particular areas of one particular part of Colombia to look at what that looks like, to get right down to the very granular level of individuals and communities in villages. So it's that kind of study rather than the broad survey. So in a sense, it complements the kind of broad, large data studies that we were talking about a little bit earlier. So what we're looking at, where we're looking at, so we have a series of in Project Speak, Work Package 1, Work Package 2, and Work Package 3, all really inventive names. We did a kind of the first element of this is basically a survey of what does the landscape look like, what does the policy look like, what does the Colombian government say it's doing, how does that relate to international guidelines, do they relate to international guidelines or not? What is in there and what is missed out, and what does the formal system actually look like, and what does its reach look like? So we've done quite a lot. It's again, as you'd expect from a mixed team, it's very mixed method. So we've done a lot of kind of systematic analysis of documentation, but we've also done interviews across a whole series of different people at relatively senior levels. We've also looked at significant data sets. So we've looked at data sets that, for example, map things like suicide rates, and basically got data sort of mapping that against where there's access or lack of access, that kind of thing. And we can talk a little bit in a little bit more detail about that with my colleague Monica over there and Sarah Jane. We are currently doing Work Package 2 and Work Package 3. And the idea, as you can see from this, is we've got macro, meso, and micro. So we're trying to work our way down. And as you can imagine, the large data we deal with really isn't a macro system. And then we go right the way down to case studies of young people in community settings. And that's the bit that we're sort of about to embark on, really. We're in the middle of doing the meso system stuff, which is about kind of taking the national data that we have and saying, well, okay, how does that map out, and what does that look like in the Pacific region, in the full knowledge that the Pacific region is a very specific context within Colombia and may not have the features that the national system says it ought to have. So we're looking at a lot of that. Most of that is qualitative. With community organizations and public health staff, there's a lot of meetings in this research, a lot of focus groups, a lot of workshops, a lot of we were looking yesterday at some really interesting groups at community level who'd been doing various forms of arts projects around how to express their feelings about particular things, whether that be people who've gone missing or ideas of maleness and male role models or lack of male role models, ideas around violence, what that looked like in the community, differences between how juvenile boys and girls view themselves in relation to the society and expectations and all of those kinds of things. I mean, very, very fascinating if you're into that kind of thing. For me, it's very interesting to compare that with work that I've done in other contexts. So I did a lot of work in Rwanda using art with young children, in basically getting them to express themselves through drawing their experiences on paper. which is really good, because quite often they find it very difficult, particularly when they're younger and they've been traumatized, to express things verbally. The other really interesting thing that I did that I was talking about a little bit yesterday was that the Maoists in Nepal, very similarly to the FARC here in Colombia, have a very high proportion of female fighters. And these are not just female fighters. So when I used to go and visit cantonments in Nepal, the women would not serve you coffee or tea. That was always done by a man. And lots of the officers, though, were female. And at the end of the war, part of the expectation was that everything would go back to normal. And what normal meant partly was that there'd be normal, so-called normal gender relations. So a number of these women who'd had command roles, usually over groups of men, were expected then to go back and do the cooking in the kitchen. So why should they, was the question. And I don't know if you've noticed here, but certainly internationally, there is a particular way of portraying female competence who exist in wars. Particularly the insurgents. There's a kind of heroic posture that you see sort of female competence take up. And there are particular forms of mythologies that form around female competence in particular, both locally, where they tend to be quite often shunned by local populations for a whole series of different reasons. In Nepal, it was largely around caste. So many of these women were low caste women. Most of them, more than 90% of them, say that they joined the Maoist movement because they've been subject to some form of domestic violence. So there were a lot of kind of preconceived ideas about who these people were. And so the study we did was we tried to get them to compose their own picture of themselves. So instead of us going in and taking photographs of them, well, how would you like the rest of the world to see you? And would you like to write a paragraph about who you are and how you see yourself? Which actually was really surprising. My favorite one was a woman who'd been a company commander, and she actually had invested her money in a bee farm. So she made honey, and she had all of these beehives. And she was standing at the front, partly in her uniform. She had her sort of camouflage trousers on, and she was standing in front with her arms crossed like this, looking in a sort of power pose. And in the back, in the corner, was her husband doing the washing up, which I thought was quite an interesting sort of imagery to sort of, this is how she wanted to be projected to the world. So this is essentially what we're doing. You can see why my students think that I wander around talking all the time. I just tell stories constantly. So results of the study, I said at the beginning, these should be sort of viewed with a little bit of caution because we've just started doing this. But we've been looking at how it's sort of defined, how people define mental health and different approaches to mental health. And there's a kind of set of clear ideas of how people tend to focus on mental health in these kinds of contexts more generally, and also in Colombia. So this idea around medicalization of mental health is something that I think is very common, and a lack of a sort of talking culture. And we think that might have something to do with a whole series of different things to do with traditions and how people view mental health, but also maybe a certain stigma involved in talking to former combatants and all that. That certainly happens in other countries. I wouldn't necessarily say that was something in Colombia, but that certainly happens elsewhere in the world. I think some of this has kind of led to a bit of a gap in provision for whole population level mental health support, rather than individualized, you have a mental health issue, come and see me as a patient, and I will treat you as a medical patient. Some of which may be completely reasonable. I'm not criticizing that at all. But we think that there's a kind of space there that at the minute is slightly uninhabited around broader talking culture. I think also that we've sort of discovered the importance of the education setting at the very local level, at the community level. And we think that there's a really, really important role for school teachers to play in some of this at community level, because they are the people that tend to see children and young people probably more often than some of their families, to be honest. So I think that there are things to think about the nature of provision and policy that we could talk about. And I think that, over-centralization. I could walk into any country in the world and talk about over-centralization. I think Colombia is not alone in terms of over-centralization. I think this is just something that governments do. It's a government thing. But I think it is something where you have a country where you have some regions that are very well provided for and some regions that are very poorly provided for in terms of formal provision, formal services, and also where you have difficulty in access. So lots of the countries I work in Africa, for example, it's just physically difficult to get to a lot of places. There aren't roads that go to villages. So one of the things I might mention in a bit is one of the systems that we used in Sierra Leone and also a bit in Uganda is we trained a lot of paramedics and we gave them all motorbikes so they could go up and down tracks in and out of the rainforest and access a lot of these places. There was no way any doctor was ever going to locate in those places, but we also created a system of mobile clinics so that what happened was that the paramedics who were there on the ground and got to know the patients and the communities were able then, if there was something that needed escalation to a formal medical intervention to a doctor, they knew that a clinic could be called in, or they knew that a clinic was going to be in a particular district capital, for example. And then they could help people get from their villages to the district capital. Yeah. So this, you'll be unsurprised to hear some of this. I've already mentioned some of it. It's my usual thing of completely ignoring my PowerPoint slides and going in order. But we talked a little bit about youth being specifically articulated as missing from services. So this comes from a lot of people who were talking about there's not enough about youth in there, not enough about juveniles. They talk about most legal documentation talks about children and it talks about adults. Whereas actually most insurgencies are about juveniles. Yeah, so most insurgencies, I'm not an expert on the FARC, but what I know about the FARC and the similarities with the Maoists are that what you do if you're an insurgent is you either kidnap people from school, which some insurgency movements do, or you inculcate them into the movement very, very young. So you get them to do things like smuggling food, smuggling bullets, running errands, making them feel important, and then they graduate to being kind of full soldiers in the insurgent movement, usually very young, usually around sort of anywhere between 10 and 12. And then, they become full fighters by the time they're 13. So you're talking about very young kids here. In Sierra Leone, kids between 12, 13, 14 were put in charge of roadblocks. So when I first went to Sierra Leone, just before the peace agreement was signed, you used to get these heavily armed children, effectively, on roadblocks. One of them was very famous for having a monkey that had a sort of thumbs up, thumbs down. And if the monkey gave a thumbs up, they'd let the people through the roadblock, and if they gave a thumbs down, they'd kill someone in the party. So this is what happens if you give a lot of 13-year-old kids weaponry, essentially, and no rules. I think it would also be silly not to recognise the impact of COVID-19 on service provision more broadly and what that looks like. And I think that's right the way through the things that we've been talking about. It's very easy to criticize services, but when services have effectively been in abeyance or people haven't been able to run services, it's quite difficult to criticize them. And I think one of the things that is particularly important that also doesn't necessarily appear in any of the documentation at all is about intergenerational conflict. It is really not an accident that most of these movements internationally are run by young people who are rebelling against older people, right? And it happens everywhere in the world. It's a youth rebellion is kind of one way of seeing it. And I think we need to acknowledge that, and we need to also acknowledge the effects on mental health of the frustration that kind of leads to that sort of thing, and the frustration then of having gone through an insurgent movement and the lack of empowerment that a lot of young people feel within those communities. Yeah, I think this we don't need to say very much about it. I'm sure most of you are kind of familiar with this. This is some of our analysis of Colombia. So when I was talking about earlier about looking at data sets, so one of the things that we looked at was kind of distribution of adult mental health beds in Colombia from some of the Colombian data itself. We also kind of mapped on things like suicide rates. If anyone's interested in any of this information, then it's all going to be publicly available, and we can make it available. I think one of the things that we found was that really worried us, because it was something that we didn't build into the original project parameters, was looking at the prevalence of suicide and how that related to lots of other aspects of mental health. And I think finding kind of a high prevalence of suicide amongst teenagers was actually quite worrying in particular parts of the country. And maybe unsurprisingly, there was an association between a lower number of professionals in mental health care and higher suicide rates. So in some ways that's a kind of very obvious thing to say, but when you see it in the data, it becomes very stark that actually a lack of access to these kinds of support mechanisms does lead people to take a really properly drastic action. I think I mentioned some of this. There are a couple of things that we thought when I spoke to Herman about this. He said, "No, Paul, you're absolutely not making a presentation. So you're coming in and you're giving a talk." And so we asked, what do you want us to talk about? And one of the things that we thought might be useful, and we thought you may be interested in asking questions on, would be in kind of examples of diversifying the workforce through the use of paraprofessionals, for example. So this is the way that the UK is going. This is the way that an awful lot of countries that are in similar positions to Colombia are going. So Nepal has done the same. Lots of countries in Africa are doing the same. The UK, and Sarah Jane is the person who talks about this, has just had a kind of mental health green paper, which talks about the things that I was mentioning earlier in a Colombian setting about the importance of teachers. So it's talking about mental health support teams in schools, so at the very, very community level amongst children, and what that looks like. So what I'm not talking about is a load of psychiatrists going into schools. What I'm talking about is people who are trained in some sort of initial ability to triage mental health issues, who then can refer these up to people if they need further professional help, or into other services if they need that. So things to do with kind of drug addiction, alcohol addiction. The other thing I should have mentioned earlier is one of the big things that characterizes populations of former combatants is actually very high prevalence of drug and alcohol addiction rates. So I think I was in a camp in South Sudan where I'm sure I was the only sober person in the entire camp, which is kind of worrying when everyone else is armed and you're the one who isn't. It's quite a sobering experience. I think I've told you the example around Sierra Leone and Uganda, which is about using the kind of paramedics on motorbikes, which I think is a really practical way of doing it. I think the other thing that happens in a number of countries in Africa is an expansion of services that already exist at community level. So in particular, midwives. So midwives are a group of people, or people who, they may not be medically trained midwives, but they may be the person who is acknowledged as the person who helps people to have babies in a village. So they're de facto midwives, really. And actually skilling them up to do a few more other things is one way in which some African countries have managed it. So you're not just a midwife, but you effectively become what we would call in the UK a district nurse. So you become a more general health practitioner. So you're able to make an initial assessment and do some of that triage work that you need at that local level. Some of those systems are really good and they're really practical, where you have very sparse populations, but spread over enormous areas. Yeah, so one doctor can't cover the whole area. I think that part of the rationale for that is the kind of pressure on specialist services and a kind of huge unmet sort of youth mental health need, particularly in the UK, which Sarah Jane is much more articulate talking about than I am. And we have an emphasis in the UK on early intervention, which a lot of these systems that we're talking about also come. So this idea of triage at an early stage, before you get to the stage where you actually need a doctor, so you can actually be sort of sent off into different forms of treatment or different forms of counselling or different kinds of community support, I think is really important, because quite often by the time that if your mental health has deteriorated to the length of when you really need sort of professional psychiatric help, it may well be too late then to bring you back into the community. And so I think looking at those things is something that we have just started to do within the research, really. Yeah. So future research, this is the last slide, don't worry. I'm sure it's the last slide. Is it the last slide? It is the last slide. I told you I ignored my slides. I think there are some other research gaps that we've sort of touched upon. One or two things that I sort of mentioned earlier that I think are really important. I think the first one is women's mental health, which is linked to trauma. So quite often there are interventions based around sexual and gender-based violence, and particularly at the end of pretty much every peace agreement in the world and every conflict in the world I've come across, whilst violence directly connected to the conflict has gone down quite often, what has spiked has been domestic violence. And whilst there are interventions around what that violence looks like and avoidance of that violence and all of that, there's very little that actually deals with what are the mental health impacts of that on the women who have suffered sexual and gender-based violence. And actually, I think that's something that's a gap in the literature, and something that I think we'd probably want to look into much more. And that again links to the kind of domestic violence elements in the second point there. I think addiction, which I mentioned earlier. So I worked for several years with a guy who'd been a former combatant in the Zimbabwean War, the Rhodesian Zimbabwean War, in the 1980s. He had the very English name of Jeremy Brickhill, and he was very English. And he was very interesting because he had originally fought for the Rhodesian army, so the white Rhodesian army, against the insurgents. And he was a special forces officer in the Rhodesian army. And he woke up, he explains it, that he woke up one day and he said, oh, I'm on the wrong side. So he changed sides and he joined Zipra, which is one of the nationalists. And he was trained by the Russians in the Crimea. And he fought with Zipra, so he became a guerrilla. He became known as the White Guerrilla. And so Robert Mugabe daren't do anything against him after the peace because he was so famous, because he was the White Guerrilla, the guy who changed sides. But I remember him, 25 years after the conflict, when I got to know him really well. So this is kind of, maybe 2005, something like that. He said, he's still addicted to alcohol, and he still had counselling for drugs and things like that. This is a long time, and this is someone who's very intelligent. I mean, he's got PhD, all this kind of stuff. Is white, actually comes from quite a privileged background. He didn't live in poverty. He didn't live in any of those things. Still addicted. He was a very dangerous person to drink with. He was still absolutely complete alcoholic. And so when you factor in all of those things, none of which are included in pretty much any demobilization program I've ever seen. Demobilization programs are all about creating economic citizens who can then go out and make a living for themselves. This whole kind of longer perspective thing is actually what is missing from a lot of these. And lastly, I mentioned the suicide a little bit earlier, so I won't say anything about that. So I'll be quiet now. And if you've got any questions at all for any of us, then please feel free to ask. Sarah Jane, I don't know if you wanted to ask. Had I gone horribly wrong on the UK system, or did you want to say something?
Sorry. Hi, thank you very much for having us. So if you did have questions about UK system or UK mental health system for young people particularly, or wanted to talk about perhaps some of the way in which our system developed following the sort of integration of things like early intervention and psychosis services, then I'm very happy to answer all or any questions about why our youth mental health services developed in a particular way based on medical research and what that's meant in terms of policy and practice and what we're doing now. So the slide that Paul had up before, the previous slide, that pressure on specialist services, I'm sure all countries are concerned about the rise in youth mental health problems, particularly in the wake of COVID-19 and lots of people being in lockdown for a long time, but the trends were there prior to that. It's just sort of turbocharged that process. So we have very long waiting lists for specialist services, and some of the thinking about what we would do to try and meet some of that unmet need for young people was about this mental health support teams in schools, this government green paper, and how we skilled up other professionals to support early on with low intensity CBT treatments and other things. So if there are any questions that you had about those sorts of services or systems or health policy in general, then I'm very happy to answer them. Don't know, Herman, if you want to chair questions.
Another microphone?
No, I can speak loudly.
Okay.
Do you have a scaled up system in terms of severity? How do you determine severity initially, and how do you refer them to a silo or a bin of specialized practitioners?
Yeah, so I think the UK, for those of you that don't know, has a universal health system. So it's free to access for youth mental health or physical health services. And we have, I should say that I'm part of a larger team at the London School of Hygiene, Tropical Medicine and Cambridge, who have just been doing the early evaluation of how successful the government green paper is. So the specialist services that exist are the ones that are kind of linked to your large-scale health systems hospitals, and they would deal with diagnosable disorder. In between that, you've got this new schools-based system of mental health support teams, which is supposed to deal with what's called low intensity, so mild to moderate cases. what we are seeing is an increasing gap in the middle. And you'll see this in a lot of research. So Pat McGorry, you might be familiar with some of his work in Australia, talks very much about the missing middle. What do you do with a population that is not meeting the threshold for clinical needs? And so referring into those services is ineffectual because they're not actually going to meet their needs and don't require low intensity services. So we have similar problems in terms of where we target our resource and how much need we've got in which particular bin, as you've called it, or bucket, or however you want to categorize it, as you probably would have in other countries. So one of the things that Monica is very interested in is how you ration healthcare systems and how you make those decisions about what services you finance and what you support. So part of our interest in comparative analysis or cross-country analysis is to look at how different places are trying to solve similar challenges, but in very different social and political contexts or very different health systems. Does that answer your question?
Yes, yes.
Perfect.
Thank you both for being here and for sharing this very interesting information. I do have a couple of questions about mental health support teams in schools, but maybe I could contact you later since it's something we want to work on. And as for the current investigation, I was wondering if when you started mapping the services, have you come across any technological services, interventions, and what's your experience on this with this particular group?
Do you mean have people moved things online? Because
like mental health, online services, and interventions.
So if I'm honest, the best person to ask about the community level organisations would be the two senior research fellows who aren't here, so Francie and Sane. So I will defer to Francie and Sane to ask about specific organisations in Colombia, and it's a great question, so I will get back to you. I will give Herman will ask them and give them the answers, because I don't know specifically in Colombia. I can talk about the UK.
Yeah. We are looking for any different strategies in mental health, even governmental and NGOs or communitarian, etc. In the Pacific region, there is so few examples of the use of technology. One of them is in Buenaventura, when telecounseling service of Dr. Without Borders was working for a long time. Now is closed, the project. And many of these particular strategies in our knowledge, in our findings, are not currently. Sometimes are from an NGO or a local initiative, or when university came to do something, and the people after say is pity because we used it during the time of this project and now they abandon us.
I think in the UK, what we've seen is people having to move online because we had very long, lengthy periods of lockdown. And so these mental health support teams, this initiative rolled out just as the pandemic hit. And so the teams were supposed to be physically located in school, but nobody was allowed in schools apart from specific children. The rest were all kept at home. And so the team had to move the interventions online. So there have been unintended consequences of that. So some people who don't have access to online technology, they don't have funding to have long sessions on their phone, they can't afford the credit. We have an increasing number of people who have a cost of living crisis at the moment in the UK. So they were disadvantaged. Some people didn't have a quiet space to engage in therapy in the home, or were unable to feel comfortable doing that because there were people around. But where it was quite successful, and there were some examples of people finding it very useful, was with some particularly young people, but also particularly the parenting interventions, because parents then didn't have to spend 2 bus fares, one dropping off the child and one then coming into school to have a specialist session. And also people were seen in their home environment with the children. So there have been some benefits and some challenges of online technology. And I think it's one of those things that we don't yet know enough about. I think one of the major challenges for youth mental health services in the UK that have delivered a lot of service online is that for a very long time, young people asked for services in ways that were flexible, that fit around their own needs, that they wouldn't be discharged if they didn't attend their appointment, and that were in this online medium, and that was not facilitated. And then it was suddenly facilitated in the pandemic. And then there's a suggestion that some of it might be rolled back. And so we're in a difficult phase of not really knowing what services are effective, what therapies are effective, what should we be doing, what's more difficult. So, for example, if you need to do physical measurements or you're concerned about someone who, for example, has been losing weight and they continually prefer the online option, managing risk has been very difficult. Oh, sorry. Managing risk has been very difficult for clinicians with online interventions. So I think the evidence base is building, but we don't have a definitive answer about what will be kept online and what won't. And funnily, it's also influenced by professional preference. So some professionals don't like working in that way, and some do.
Just one quick thing, that it's not necessarily about high technology, but something's been used with formal competence in lots of other countries has been a kind of medium level of technology, in particular mobile phones, because internet, the availability of the internet is extremely patchy in large parts of Africa, for example. But strangely, you know, even if you can't get clean water, you can get a mobile phone signal, and everyone's kind of obsessed with mobile phones. So the use of mobile phones has grown kind of exponentially to deliver a whole load of services, but also to collect information. So there are a number of different projects with formal competence where the old way of dealing with formal competence was to train them in something and give them a load of money and send them off into the big wide world. But actually, that was really dysfunctional, because the first thing they do is go out and get drunk, and then they'd buy a motorbike or something, and then they'd have no money. And so actually, where that is developing is down a whole list of different kinds of support in kind that are offered instead of big cash sums. Part of that is around provision of mobile phones and the cards to go with them, so they can use them both to receive payments over a period of time, but also to report what they would call everyday incidences, and that would include things like medical health and mental health and medical ailments and all of those kinds of things. So that's kind of in its infancy, but that level of sort of middle level technology is something that is certainly has huge potential, I think, in areas where maybe, you know, high-end rapid internet is not the norm.
Yes.
Thank you. Thank you. Okay. Thank you for sharing this wonderful work with us. It's very enlightening for our country. My question goes to which has been the experience with LGBTIQ plus population. We know that this kind of people is really vulnerable in this kind of armed conflicts and stuff like that. And I have seen that in future research, you have like women's health
Yeah.
as one of the targets. What about these targets of the mental health of these people?
Yeah, I mean, I think that is something that we haven't necessarily talked about within this specific research project, but I think it is something that internationally is I think you're right to settle on it. What I would say is that in large parts of the world, the position of LGBT plus people varies according to what society in general thinks of it, but also at a local level. If you're a combatant and you live in a particular sort of society, what that localized version of society looks like. So in lots of places where I work, for example, particularly in Africa, a lot of the local law and justice systems very broadly are mediated by a local chief. So you won't really have access to you might have access to a district court, but that'll cost you money, and you'll have to travel to the district capital. You'll have to do all of these things, and so people don't access those. They go along to the local chieftain court, and the chief's important because the chief, who is always a he, will control access to land. And that means that if you have land, you can get married. If you don't have land, you can't get married. We were talking about this a little bit yesterday, that when I very first went to Sierra Leone, I was very young. I was in my early 30s. And I met someone who was kind of my age, in his 50s, who described himself as a youth. And I was kind of, youth, what are you talking about? Because in large parts of the world, the category youth has got nothing to do with how old you are. It's whether you've graduated into being a full member of society. And many people who are LGBTQ plus never graduate into being part of society. Because if you talk to chiefs about how they enforce justice, they'll tell you that actually that's their form of enforcing social hierarchy. So if you're regarded as deviant in any way, shape, or form, and that maybe a whole range of other things, then actually you're excluded from much of this anyway. And so actually you have a kind of lower sort of status within society. And I think you're right that that's a group of people that is invariably missing from a lot of approaches, partly because of that. So I'm not an expert in what that looks like in Colombia, but I can certainly say that within work we've done in Uganda and also Sierra Leone. In Uganda, it's explicitly illegal to be gay. So it's very, very difficult to deal with people who are LGBTQ+. I mean, the fact that it's illegal doesn't mean that they don't exist, obviously. It's completely insane. So dealing with people who have those kinds of problems is extraordinarily difficult if you're in a formal medical setting. So you have to go down the much more kind of informal routes. And they are, to be honest, they're very, very badly served. And every day there are stories of people being beaten up and all the rest of it. So I think they are something of a forgotten group. So but I think for all the reasons I've just outlined, I think they're particularly important because they really are an excluded group, but for a number of reasons.
Yeah,
You want to talk about the UK system?
I do want to talk about the UK system. So thank you very much for the question. I actually have a colleague who's just finished a very large piece of health-funded research called Professor Liz McDermott, who's developed a range of resources about how you include young people who are LGBTQ+ in mental health services and how you better serve them based on some findings and co-produced outputs with young people. So I will send the resources because they've just been published nationally to Haman, and I think they might be really interesting about how you better engage as clinicians all groups of people. I think it is a gap for us in terms of potential future research. We can put everything we'd love on the wish list to do in the future up there, and we do have colleagues who specialise in different areas. In the UK, we call them protected characteristics. So gender is one, LGBT sexuality is one, race is another. So we are interested in looking across what we would call in UK parlance the protected characteristics. And I think particularly for work package 1, which was the documentary policy analysis, it was mentioned but fleetingly, so it doesn't have a prominent place in mental health policy yet in Colombia. So it would be something for future research, but to build an evidence base to then inform your policy development locally, as well as looking at what's going on internationally. But if you do have an interest in either resources about how to work or the kind of policy systems side of it, then definitely drop me an email because I'm happy to send you some further things if that would be useful.
Thank you so much.
We'll go here first and then.
Thank you both of you for sharing your findings. I have 2 commentaries. Dr. Jackson talked about in order to not medicalize mental health. As you know, we have a new program, a new registering program. What do you suggest about in the medical training, how to support that idea that is important to link with other disciplines about mental health? And the second question is about poverty and discapacity people or children. How do you work with that population?
So I might start with the first one, and then I'll come back to the poverty. I'll let you think about poverty for a second, Paul. So I think for a very long time, people know that there are very few people left practicing medicine or who train who believe in purely a medical-only model or have a very disease-focused only approach in mental health, because there are a range of causes for mental distress and some things that lead to sort of serious disorder or mental illness. And some of those things are adverse childhood experiences, trauma. Some of those things are linked to poverty. And I think what's very difficult and what will be increasingly difficult is as we have greater proportion of young people identifying with need, how you work out what's a medical concern and what requires a multi-agency, we would call it, or other solutions. So what will require other professionals to support that child, because actually it's the context in which they're living of domestic violence or poverty that's creating the mental distress. And there are no easy answers to that. I think for you as kind of a population who are leading a medical school, you will have similar challenges to some of the medical trainees in the UK. So I work in youth mental health research and I look at service access for young people. And invariably, young people say that they are told that they need to get more unwell in order to get a service, which is a perverse incentive for a young person. A logical young person will demonstrate more symptoms in response to being told you're not sick enough to get a service here. For a trainee or for a very experienced professional in a hospital, when someone presents with very serious self-harm and suicidal ideation in an accident and emergency room, or with a problem, you can't tell whether that is a natural response to stimulus, something that's conditioned by the system, or whether it's impulsive and generated by mental distress. It's very difficult to differentiate between the two categories or to manage that risk. And so actually, I think part of the solution and part of the reason why it's important to engage in interdisciplinary work as a clinician is partly because the system, if it makes people sicker, is not serving you or the population of interest. And so it requires thinking about the whole system so that you can effectively diagnose and treat. So I think there are some very easy ways in which you can take a case study approach to trying to get people to think about what might have caused this and what might, in our communication pathways with young people, generate further distress or help them feel invalidated so that they present again with more complex symptoms versus those whose risk is escalating because of the condition. Is that the sort of thing you were thinking about in terms of why you need a multi-pronged approach? But there are lots of different examples of things like that, and I'm happy to I've got some case studies actually, because I do quite a bit of teaching across different courses, so I'm happy to send some case studies from research about young people. You'll have very similar stories here, even if you went round your accident and emergency room tomorrow, someone would be able to tell you a similar story, so you can supplement them with your own cases. But I think there is something about understanding the wider picture. The other thing I think is really important is about how we measure in what Paul was talking about, the big survey data, epidemiological data. There's very little discussion about how the system influences what we measure. So if you make it very difficult, as we did in the UK, for young people to access services between the ages of 16 and 18, and then you look at all your data points, but they haven't been able to get into service, and you say, oh, well, youth mental health, it starts very young, and then they're very ill in kind of early adulthood, but you've had this huge gap in access, you're measuring your service and your system, not sickness. And I don't think we have an honest enough conversation about how our systems, our health systems, and how we structure our services and how we then fund them accounts for those sorts of gaps for young people in provision. So that would be my other pause for thought when you're thinking about how to challenge kind of training and medical students to think more about policy and systems that they work in and what that might mean in terms of patient access pathways and why people end up in distress presenting rather than being seen earlier. I'll talk about poverty, Paul?
Yeah, I'll talk about poverty in a sec. Just a couple of things to add to that. I think one thing that, I mean, Sarah Jane talked a little bit about the UK NHS and the way the UK views it. I think it's impossible to overestimate how much debate there is about all of these issues that we're talking about in the UK, just amongst the general population. So if I go home and I turn my TV channel on and I look at the news in the early evening, there will be a story about the NHS and service provision and all of that. And it'll be kind of in the top 3 stories on the news every single night. So that the whole population is involved in the discussion about how to ration resources in different ways within the National Health Service. So it's a National Health Service not only in terms of how it actually delivers health, but in terms of how we as citizens of the UK think about ourselves, if you like. I think the sort of important thing around your first question is that as you know, in any field, as research progresses, the ideas of what constitutes mental health, for example, expand, and so previous ways of doing things then become out of date, or they don't necessarily expand at the same rate or into the same areas. And now, even within the medical profession internationally, you would know this better than me. There's much more of an emphasis on hybrid approaches rather than just, oh, you're very sick, here's a drug, which is very much the kind of old-fashioned approach. Sorry, I'm caricaturing an entire medical profession while studying in a medical school. I didn't mean to do that. But I think the kind of hybrid approaches bring much more, which is what I mean about the sort of talking culture as well. So and I think working, and just to move on to the working with people who are in poverty, I think it's not necessarily just people in poverty, but I think people who live quite isolated and sometimes quite enclosed lives in villages, who never stray very far from their villages or their family home. They may never have been to Bogota, for example. They may live in a kind of rainforest or in the mountains or something like that. If a medical professional turns up, that is enormously intimidating. You know? And we have the same argument. I have the same argument all the time, because I'm a director of research within my own institution in Birmingham, that people say, well, people should come onto the university campus. And if you see a photograph of our university campus, it's a massive, it's the original red brick university in the UK. So massive buildings, huge clock tower, lots of parks, lots of people wandering around with kind of professor labels on them. Who in their right mind who's never been to a university is going to feel comfortable going onto that? Yeah. So I think there is something around working with people who are in that position where you need to become much more humble and much more aware of the context within which they live. And not everybody is happy with that. I think, as I gave a talk yesterday at the university, and I was saying that the other thing as a researcher, particularly if you're a PhD researcher or you're doing field work, is that answering your questions about your research is not the most important thing that person will be doing today. That you should feel privileged that they're actually bothering to answer your questions, because otherwise they'd just be getting on with their lives. And I think sometimes there's definitely, as researchers and as professionals going into those kinds of environments, quite often there's an us and them approach, and there is a divide. And I think we need to be very careful about that. And that is why an awful lot of people who live in those sorts of environments are very, very, we would use the word cagey, so very nervous about working with people. So when I used to work a lot with the Maoists in the hills, and I would spend a lot of time in old kind of Maoist safe houses and on farms and things like this. And it would be very interesting, because they would spend at least a couple of hours working out if you were a human being or not. And then once they decided you were a human being, they might come and ask you a question, or they might sit and have a beer with you, or they might ask someone who knew you if they could talk to you, kind of thing. And actually, I don't blame them, because almost their entire engagement with anyone who was identified with an outsider or a state was probably been negative, particularly if you lived in a conflict. So all they've seen is people come from different organizations and shoot other people or perpetrate violence in some way or shape or another. They're a threat. The state, quite often, and state service provisions represents a threat to them, not a help, because that's all several people have ever experienced out in many of those different communities. Either that, or they just don't know what you're talking about. And I think there is definitely a kind of I think sometimes as professionals working in those environments, we fail to really properly understand the context within which these people lead their lives, and that I think is a good place to start.
Just on the poverty thing, I think one of the interesting things about comparative health systems research is looking at access and what happens if you have financial barriers to access for young people. And part of my PhD research was in Australia, and I've always admired some of the Australian services because they're very innovative, and they led the way in a lot of the early intervention in psychosis research along with colleagues in Birmingham, and it's part of the reason I chose to do a dual award PhD. And I was quite surprised by the access issues they had. So firstly, it's geographically massive. So there were some young people that would travel 2 days to a psychiatry appointment and then 2 days back. And so there they've done some innovation in telemedicine, telehealth, because they've had to. Doesn't necessarily mean all young people don't want to be seen in person. So there's some issues there about choice again. But one of the things that they are still grappling with is the way that their health system is structured around funded payments. So you can have 10 sessions on the National Mental Health Care Plan. If you need And young people are quite astute. They decide when they're going to use them and how they're going to use them. But there is often a kind of top-up payment in some states, and it's federalized. So everywhere has its own mental health legislation. There's a federal plan or a federal program, and then there are state-run services. And I think this is, again, this kind of interest in how a system can pattern access and also how it can condition clinicians to work in very particular ways. And actually, if you're a young person, if you think about it logically, you're not very financially independent. You go through kind of childhood and you reach kind of latency and you end up in adolescence, and then you may or may not have access to employment, part-time casual employment, but you're certainly not going to be economically sustainable until later adolescence. And if that is a time at which you're becoming quite unwell, you're going through family breakdown, parental divorce, anything, and the finances in the family are strained, the co-payments or the part payments or any additional payments for your services are going to be very difficult to resource. And so actually I was, whilst there are some things to admire in other systems, there are also cautionary notes and things to learn about what happens if young people can't afford access in a very basic sense to additional services. And what that means for how you design and develop health systems in other contexts. So again, lots that I could talk to you about in terms of financing health systems, and Monica, I'm sure behind you, is happy to talk to you about rationing and access. That's another point. Thank you for the question.
Thank you. A couple of questions.
Yeah.
Oh, yes, sorry.
Yeah, I have one question. Thank you again for the presentation, but I was wondering, within the context of the need to diversify the workplace, I was wondering, how did the educational process of the education of the paraprofessionals take place? And for example, Sierra Leone with the paramedics, or in the UK with the teachers, how is this whole educational process? Because it can be quite lengthy or expensive, and it can be difficult, especially for people in rural areas.
Yeah.
In which,
So the UK paraprofessionals who are working in these teams, they're mental health support teams. So they might have a clinical lead, but they're called educational mental health practitioners, EMHPs, and they have 1 year's training to they go to university for a year to deliver these CBT low intensity interventions and to triage and assess. But they also use that training to map local community services, so to refer on to other services. So it's they're kind of, those professionals have this 1 year training, so that's partly why they're called paraprofessionals. So they're not going for a full accredited professional qualification, such as a therapist or a medic would, but they are working in this support role. And one of their roles, in addition to that, part of the green paper was to identify in every school a mental health lead. So there's a specific teacher, a senior teacher, who's trained to support the culture in that school. And so they've got this team that comes and delivers direct interventions to children, but they also do whole approaches in the school. So they might come up and do kind of emotional literacy in assemblies or other interventions for everybody, as well as kind of focused interventions with children who are identified as in need of support. So the teachers themselves don't deliver therapy or therapeutic interventions, it's the paraprofessionals, but they help identify and create what's called a whole school approach culture. So a culture of being able to talk about mental health. And that's particularly important for your colleague who was asking about things like tolerance of LGBTQ+ issues in the classroom, all those sorts of things. But if you want to talk about paraprofessional training in Uganda.
I'm going to give you a proper academics answer and say it depends. I would say the short answer is that a lot of the stuff is very similar in terms of what they do. So you're not taking a full medical set of qualifications when you're training some of these people. And it's usually a mixture of people who may have had some medical training, or within the African context, for example, there are an awful lot of people who exist out at community level who may have had a little bit of medical training to do with things like mass rollouts of vaccination programs. So if you think back to things like Ebola in West Africa, for example, the nationally focused Ebola strategy that Sierra Leone had didn't work at all. That's because people didn't trust the national strategy. But so they changed completely, and they fell back on these the sort of para elements and the community-based elements, and actually the population trusted that. And in Ebola, although it's a medical disease, it's really, you cure it by administrative measures. You stop people getting together, really. So what it requires is a bit of management now rather than anything else. But that requires a lot of trust in a situation like West Africa, where the main spread of Ebola was through bodily fluids to do with people dying, and there are a whole series of rituals to do with what you do with the body and all of that kind of stuff. So it required a very, very high degree of trust for people to get involved. So there's a whole network of people who kind of have a little bit of medical training. I would say, though, that in large parts of Africa, where there is very little national or domestic funding, that actually most of this is provided internationally. So people like the Gates Foundation, people like that, train sort of district nurses, midwives, those sorts of people, usually through the national kind of Ministry of Health of the particular country involved. One of the interesting particular things around formal competence as well, though, I remember having a big set of discussions about this in Nepal, was that within the Maoist movement, which is very much like the FARC, had existed for a long period of time, controlled large areas of the country, ran their own clinics, all of that kind of stuff. There were quite a significant amount of medical skills, basic medical skills within that movement themselves. And in fact, as part of the retraining exercise, several of the former Maoists chose to train to become more or less district nurses, both male and female, because they already had a standing start. So they already had some medical training. Quite a few of them had battlefield experience of dealing with things like bullet wounds, for example. And so it was a relatively short step to train them just a little bit more to do things like how do you recognize issues around mental health, or how do you recognize issues around maternal health complications that may need you to need more than a midwife to deliver this baby. Yeah, so we're not talking about huge steps, we're talking about incremental steps to add to existing bits of training, which has been, I would say, quite successful, although I would say that with a little bit of trepidation, because your benchmark is zero support. So you're going from zero to a bit of support. So a bit of support is always better than nothing. But all of these programs are kind of, most of them haven't been going for that long. So, yeah.
I think what would be really kind of helpful, if you take anything away, is that the need for a sort of a focus on the general population's mental health, as well as specialist services. So in Colombia, it might be specialist services for people affected by conflict or who've been involved directly in conflict. How do you create services for everybody whilst ensuring you've got enough resource for people who are really struggling and suffering? And I think partly the UK has demand and supply issues of its own in youth mental health, as do most countries at the moment. And there is no one perfect answer. And as Paul said, it's very context driven. So this is partly why we're saying, as you go through your training, I know you're focused very much on treating an individual, but do hold in mind an interest in the wider system in which you're treating that individual, and what else you might be able to do, or research of your own that you might be interested in engaging in about how you develop interventions or work in different settings.
Well, thank you very much. Thank you. Unfortunately, time is over, and you can imagine how this topic and your reflection and experiences came in a very crucial moment here in this country, when we are talking about the reform of the health system, and how can include the mental health in the new or the modification of the current system, etc. And sometimes we observe this confrontation between one side or the other side. The things are not white and black, of course. So with your experience and your important findings of your research projects, etc., and your experience in different parts of the world, teach us that it's not maybe the things very white or very black. We need to build some middle solutions, some middle strategies, and as I mentioned in the beginning, one of the most important things that we are that we know of your experience now in this project is this kind of different strategies that is not this super specialized and not at all only the community. So maybe in the middle. Thank you so much. Thank you. Muchísimas gracias. Muchas gracias a ustedes. Muchas gracias a las personas conectadas y en nombre de la Fundación Santa Fe, la Universidad de los Andes y el posgrado de psiquiatría, muchas gracias a todos por su asistencia virtual y presencial. Muchas gracias.